Hello, everyone, and great to have you all here on this session today. Great to have everyone here on this session today. The session is guidelines with and for users. And today we have some great speakers lined up on this very important topic, where we are really interested in seeing how users are engaged in developing guidelines which will be used for them, but we want to really see them involved. So I'm moderating this session today with Joseph, and I've been with him on Gene for a long time, and it's really exciting to be co-moderating this session with him. So I'll introduce the speakers, and then I'll allow Joseph to come up with the questions at the end. So the first speaker on this session is Ana Pereñino de Guzman, and she's a medical doctor at the Institut Catalan of Oncology. Ana holds a medical degree with specialization in public health and preventive medicine and a master's degree in public health. She is a PhD candidate in the methodology of biomedical research and public health program. She was awarded the Rio Ortega grant financed by the Carlos III Institute. Her main research interest is the methodology for incorporating patients' values and preferences in clinical recommendations. She also participates in Great Circual. Currently, she works in the cancer screening program projects related to values and preferences of people invited to screening and communication strategies in population-based cancers. She will be talking to us today about identifying the roles of clinical practice guidelines in healthcare decision-making beyond the clinical encounter, a critical interpretive synthesis. Ana, you're welcome.
Hello, thank you. Thank you very much, Patrick, for the presentation. I will share my screen now. Okay, can you see my screen? I hope yes. And I will present this study. Okay, well, the first study is about the perspective of patients with chronic disease and caregivers on self-management intervention. This is a scoping reviews, and on behalf of my group, I will present. This is the introduction, just to tell that what are we conceived by self-management interventions. Those are any intervention that could be provided by healthcare professionals, peers, or laypersons that aims to provide patients or participants the confidence and skills to manage their chronic disease. This project was conducted as part of CompareU. CompareU is a European project that aims to identify which self-management interventions work better and which are more cost-effective, and for the 4 chronic conditions: for type 2 diabetes mellitus, for obesity, chronic obstructive pulmonary disease, and heart failure. The objective of this scoping review was twofold. First was to summarize the preferences and experience of patients and their caregivers, including informal caregivers, mostly family members, and healthcare professionals too, and how they experience self-management for the 4 chronic diseases. And the other objective was to identify in this body of evidence the relevant outcomes of self-management interventions from these perspectives. So we apply a mix of methods, scoping reviews. We adapted the ARC-C anomaly methodology. We searched in 3 databases until December 2020. We selected studies, systematic reviews of primary studies of any design, focused on adults with one of these 4 chronic diseases without restriction of severity, or including also informal caregivers or healthcare professionals of any level of care. The phenomena of interest, we were focused on their preferences on health states that could be reported by utilities or non-utilities measures, and also their experience with self-management. We analyze this data using narrative synthesis for the ones that reported utility measures and descriptive thematic synthesis for the ones reporting qualitative data. We propose a classification of outcomes that were conceived as specific for self-management interventions, others that could be modifier factors, maybe mainly known as barriers or facilitators, and also one other type of outcomes that could be both. So after looking all the three databases, we identified more than 11,000 references, unique references. We examined based on full text 448, and finally we selected 148 studies, systematic reviews. Just looking the distribution by type of condition, you can see that most of them were concentrated in diabetes mellitus, and the condition with least systematic review was obesity. And when you look at the publication year, in the last 4 years, from 2016, was almost the same amount of systematic reviews that were conducted in the previous 10 years. And looking at the type of reviews, we identified that most of them were qualitative evidence synthesis, but anyway, we included also, or we identified some quantitative systematic reviews and mixed methods research synthesis. In the amount of studies by included systematic reviews, the range goes from 2 studies to more than 200 studies. Regarding population included, most of them included mostly the patient's perspective. The least included informal caregivers, and the least ones included only healthcare professionals. But there is some 23 studies that included more than one perspective, maybe patients and informal caregivers or patients and healthcare professionals. Again, in diabetes mellitus, we find this type of studies as reporting the 2 perspectives. Regarding the phenomena of interest, most of them were focused on the experience of self-management process. That was our approach. We had a broad approach trying to identify not only studies that were conducted in the context of a self-management intervention, rather we included all studies that reflect what is the process of self-management in this type of patients. Well, after doing the analysis, we identified 12 main themes that were categorized in three sections. The first one is related to the experience of self-management. That means the process of the patients to integrate self-management as part of their everyday life. So the first topic here, the first sub-theme was the progression of the disease. This progression can be explained by the change in the physical functioning, psychological distress, complications, mortality, their behaviors, their self-management behaviors, like, for example, adherence to treatment, the importance of social support in this process of experiencing self-management, and also the other pillar is the interaction with healthcare professionals, how they perceive the quality of care, which are the number of visits and contacts. Moreover, we identified a second section that refers to factors that influence self-management. The first one was access to health care, then the cost or resources they need to expend to integrate self-management in their daily life, the perception and roles, and also another big topic was the health knowledge. And finally, we included some topics or some themes that refer to what was actually the experience with a self-management intervention. This experience will be influenced by the previous one, by the experience of self-management, the factors that influence self-management. So depending on these previous themes, the experience will be affected. One first theme specific for this section was the perceived benefit. the perceived benefit of a self-management intervention will be affected by the perceptual barriers, could be physical, psychological, or the how patients perceive they have a technological literacy. Other aspects refer to the how is tailored the self-management intervention to the preference of patients. So what is the extent of individualized care? And on the other hand, also, what is the sense of community they get from being in this experience? And the final thing was usability. After just including all the previous topics, just to experience how applicable is the self-management intervention for patients in their everyday life. In this graph, you can see what was the distribution of themes according to the condition and also from the perceptions. Most of the topics were consistently identified for the 4 chronic conditions, but some of these themes were identified from the 3 perspectives. So we could retrieve information from patients, the healthcare providers, and informal caregivers. Just you can see their mortality was reflected in diabetes mellitus and heart failure, adherence to treatment, interactions with healthcare professionals, health knowledge, and perceived benefit. And in the last extension is about obesity, just to highlight that we didn't identify the perspective of informal caregivers in this specific condition. And as we mentioned before, we also classify the outcomes based on the themes and the sub-themes we identified. We made this classification of which outcomes could be specific for self-management intervention. These are listed here. For example, self-management behavior is actually specific for self-management intervention, or the help or health-seeking behavior, because some of these self-management interventions are focused on this. Other factors are more likely to be modifiable barriers, actually. For example, the access to healthcare, the cost for patients, and their defined roles and perceptions. And a third group can be considered as both, can be an outcome and also a modified factor, since some self-management interventions are aimed particularly to improve these factors. For example, psychological distress and stigma. So this study was already published in Patients in January of this year. Just to highlight some main points, so we identified these 12 main themes that cover aspects of the process of self-management in the process of the disease, and what factors can influence in this process, and what are the experience specifically related to self-management interventions. So these findings can be relevant when we will consider the patient important outcomes. And this set of themes can also be useful to guide the design and implementation of new self-management interventions. And this evidence could inform decision-making, either developing recommendations or maybe developing decision aids. So far in CompareU, we have integrated this evidence. So in the draft study, the draft results at the beginning, we conducted development of these infographics, that we designed these infographics just including the outcomes and evidence reflecting for the perspective of patients, healthcare professionals, and informal caregivers. And this material was circulated among the people who identify or selected the core outcome sets for the 4 chronic conditions. That would be all. Do you have any questions?
Okay, thank you very much, Anna. Joseph, over to you.
Yeah, thank you very much, Patrick. And thank you, Anna, for a very nice presentation, very crisp and clear. We now open this presentation to questions. So everyone who's on this session is invited to type in the question and answer live box. And as they come in, I will read them out for Anna to answer. Thank you. Okay, we have our first question from Yi Chin Ong, who's asking that she's just wondering about how the results would be affected if the patients had more than one of the 4 chronic conditions. Over to you, Enna.
Yeah, it could probably be affected. Fortunately, some studies included this type of subpopulation, and we could gather the evidence that reflect this double burden or triple burden. Yes, it's reflected in a different way. And most of the studies, their systematic review, were focused in a single condition. That was we identified. But regardless of that, yes, there are some primary studies that could identify some patients with a double burden. Yeah, yes, it actually would be really different, this spectrum. Yes, the importance of comorbidities.
Thank you, Enna. Any other questions now for Enna, please?
Joseph, while we are waiting for the participants to throw in some questions, I could also just throw a question for Enna. I would be interested in knowing if you had some considerations for people with disabilities in particular, or indigenous people in the work that you did. Thank you.
Thank you, Patrick. Thank you, Patrick, for your question. Yeah, actually in the studies, some of the studies were focused mostly in people with disabilities. There is a high, I want to say, in the research, there is a sensitivity to this subgroup population. Actually, one finding is also that most of the studies were reflected, for example, ethnic minorities, were the primary focus of some of these systematic reviews. And there were the disability ones, we found only one, but it was highly specific for people with disabilities. Yes, but in the research, we identify that there is evidence producing specifically findings for these subpopulations. So if in real guidelines, we could assess findings that can inform these subgroups. It's available.
Yeah, thank you, Enna, and thank you, Patrick, for asking that question. I'm still looking at the chat box to see if we've got any more questions coming in, and I don't see any. So while we're waiting for any other questions, Enna, would you like to make any additional comments on what you've said and you couldn't cover in those limited 10 minutes?
Yes, just to mention that the development of a scoping review of such amount of systematic review, more than 148, was the process was challenging, because we had a variety in methodologies, a variety in ways of reporting. And one issue we had, for example, was how we define a systematic review, because the classification from their point of view was not pretty clear. So we did a reclassification just based on some consideration. For example, when we identify an integrated systematic review, if they mixed qualitative and quantitative data, we consider them as a mixed methods review. So we did the experience or the challenge to classify the studies, just to be sure that what we were analyzing, and that was a little challenging. And also, how well was it incorporated in the core outcome sets development? So it was positively received when we used these materials. But still, we felt that there were not enough guidance in how to integrate these materials in the process of core outcome set development. So there are still areas of research But we feel that this body of evidence could be helpful in many areas. So just we have the opportunity to have this summarized evidence in one study.
Yeah, thank you, Anna. I think that was nice. And it's pretty obvious that the work is voluminous and you've done a great job doing it and presenting it as well. I see that there are still no further questions on this particular presentation. So I think I joined Patrick in thanking Anna for a very nice presentation and a good discussion as well. And over to you, Patrick, to introduce our next speaker and kickstart that presentation. Thank you.
Thank you very much. And Anna was right on time. So the next presentation is coming from Ivan Flores, and it's titled Identifying the Roles of Clinical Practical Guidelines in Healthcare Decision-Making Beyond the Clinical Encounter, the Critical Interpretive Synthesis. And sorry, Ivan, I had originally mentioned this as Anna's presentation. Really sorry about that. So Ivan is at the University of Antioquia in Colombia and also doubles at McMaster University in Canada. He's a pediatrician by training with a master's in clinical epidemiology and a PhD in health research methodology. He's an associate prof at the Department of Pediatrics at the University of Antioquia in Colombia and an assistant professor at McMaster University in Canada. He's a former deputy director of the Clinical Practice Guidelines for Health Technology Assessment Agency of Colombia. Dr. Flores is the current leader of the AGRI collaboration, and is an academic / associate editor for the Systematic Reviews and PLOS ONE journal. He's a co-chair of the Recommending Working Group for the COVID End Initiative and the director of the Cochrane Colombia. He's also a member of Cochrane's Conflicts of Interest panel. So please welcome Ivan to this very interesting presentation. Thank you, Ivan. You have the floor.
Hello, can you hear me?
Yes, we can hear you.
Okay, can you see my slides? Perfect.
Yes, your slides are
Okay,
up.
so thank you for the opportunity for being here. Thank you, Patrick, for your presentation. So the idea of this short session is to talk a little bit about our project, which is called Identifying the Role of Guidelines Beyond the Clinical Encounter. This was a critical interpretive synthesis, and we work together with Drs. John Levis, Holger Schunemann, and Melissa Browers from McMaster University. So as a background of this project, just wanted to briefly define what we call and what is called a clinical encounter. So a clinical encounter is any physical or virtual contact between subject or patients and a health practitioner during which there is an assessment or a clinical activity. Okay, so this is kind of the most important situation in the clinical decisions. And we all know that clinical practice guidelines are mainly focused on this kind of decision, all the decisions that occur at the clinical encounter level. However, we all also know that all the decisions that we as clinicians are making every day regarding patients' care or decision by patients at this level regarding their own health with or without the support of the clinician or of shared decision, all these decisions are the main focus of clinical practice guidelines. Clinical practice guidelines are usually providing recommendations to be applied in this clinical encounter level. However, we were not very sure how much out of this clinical encounter level were clinical practice guidelines used or not. So what we know? We know that historically guidelines emerged in response to a need for standardization, cost containment, and the need for reducing variability. But they usually focus guidelines more on informing clinician decisions and patients. But at the same time, there has been most of the study and the work has been on how to make physicians more adherent to the clinical practice guideline recommendations. But we also know that guidelines are not only used by clinicians and patients for their decision. We also know that different stakeholders use guidelines for any additional decision at the healthcare system level, health insurances, and research prioritization processes, even judicial decisions. So even though we know the guidelines have been done, focused on the clinical encounter, we also know that the guidelines have been used for any different stakeholder interested in those decisions. So what we didn't know before this work was what were those roles outside of the clinical encounter in which guidelines could play a significant part. So what are these laws? How are guidelines playing this role outside the clinical decision? Are clinical practice guidelines good tools to inform decisions outside the clinical encounter? Should we use guidelines for those decisions, or should we create different tools or modify current guidelines to make them fit into those roles? So our aim was to understand what are the different roles of guidelines outside the clinical encounter, how guidelines are used in these roles. So for this, we designed a critical interpretive synthesis. This systematic review was registered in Prospero. We searched all these databases. We included articles that discussed or reported the potential roles of guidelines in different contexts. We had no study design limit. We included empirical and non-empirical evidence or reported methods or tools that have been created or have been used to implement or to use guidelines in these different roles. 2 reviewers independently screen and assess the study, and one reviewer, that's me, conceptually mapped the studies and interpreted the findings. We thematically synthesized the results and developed an explanatory framework to describe the roles that answers to the question, what are the roles, and for identifying the methods, tools, and approaches to use in the by clinical practice guideline developers in this role. That would answer the question, how are clinical practice guidelines playing this role? We follow the following step. We identify common themes and concepts from the literature. We develop theoretical constructs based on the emergence themes and concepts. We conducted additional purposive sampling of included papers, or conducted additional purposive searches to fill conceptual gaps until theoretical saturation was reached. And we integrated the theoretical construct into an overarching synthesizing argument about what are the roles and how are they played. We follow the usual steps recommended by Dixon Woods et al. About how to develop critical interpretive synthesis. We included 220 articles. You can see that we obtained almost 20,000 from this, and through all the process, we ended up including 220. Most of them were from authors from the US, UK, Canada, Netherlands, and Germany, and additional papers from other less representative studies in case of number. All the studies were published between 1987 and 2020. So in this slide, I'm going to explain our final framework about how we categorize and analyze and synthesize the roles and how we define them. So when we study what are those roles beyond the clinical encounter, we found that there were many roles in the literature, and we found that the quality of care was the most important overarching role. All the activities focused on improving or enhancing quality of care would be under this big category. Under this category, we had all the activities about development of quality standard or quality or performance indicator, all the activity about quality improvement activities that were aimed to develop quality standard, quality indicator, performance indicators, in which guidelines could play a role. We also found activities about facilitating the quality improvement and clinical governance, and also all the activity related to accreditation and certification of programs or hospitals and health services organization. All these have the final aim of improving the quality of care. A second big main role was the economic decisions. So historically, guidelines have played a role in, at some point, cost containment or making the system more efficient. So all the economic decisions that could be included here, like for instance, decisions about coverage and reimbursement decision, regardless if it's insurance or public healthcare system. Cost as a cost containment tool, it has been used as well as a healthcare rationing tool, as a healthcare resource allocation tool, and also it is used for financial incentive strategies. So these big goals, we define them as the main roles of clinical practice guideline, because historically they were developed at some point. Guidelines were developed in order to have some impact on these big overarching roles. We also have some secondary roles about their use in medical education or certification or licensing processes of specializations. So we found that inside this major role, we had all the activities that in which guidelines play a role in medical education, either for medical students or for clinical residencies, for lectures, for training, and also for continuing medical education activities, though all the CME, continuing medical education activity, in which guidelines could be a source for providing, for instance, not only training, but also that could be used for the exams that some organizations use it. Also for licensing and maintenance of certification, in which guidelines could be used to create, to develop the exams for maintaining certification of medical doctors in different countries. And also, as an interesting aim of guidelines is to inform research prioritization. So guidelines have been used, and there are some topics on how to use it to create research priority lists and to create inside the development of the guidelines research recommendations that some guidelines provide. These two major roles, we call it secondary aims, not as important as the previous one, but still could play a very significant role that could have some impact in healthcare. And we found what we call an anticipated role, which is the use of guidelines in judicial decision. We all know that the guidelines could be used as a sword or as a shield in order to be used in malpractice litigation to defend or to accuse some of the doctors that are part of this, and also for coverage disputes. This is what we call an anticipated role. And finally, how the clinical practice guideline plays the roles, even though they are mentioned in the literature, we didn't find too many tools to assess, to use these guidelines in these roles. We found some very good frameworks of how to use clinical practice guidelines to develop quality indicators, some methods to develop quality indicators from guidelines, but not tools to other roles in the quality of care. We also found some literature suggesting a closer work between guidelines and HTA, but no tools how to facilitate this collaboration, how to inform economic decision. We didn't find any tools to inform how to use guidelines in medical education, certification, and licensing. And we found some methods about how to create research prioritization list from guidelines recommendation, and we found no tools to how to use it in judicial decision. In conclusion, clinical practice guideline, although focused on informing decision on the clinical content, plays several roles beyond that level. We developed an explanatory framework that describes what roles are and explain how and under what conditions they are used. Quality of care and economic decision are the main roles of clinical practice guidelines outside the clinical encounter. Research prioritization and medical education were defined as secondary goals that require more research and further development. And the role of the judicial decision that we call an anticipated role, although controversial, will continue and might be subject of further study in some contexts. Most of the methods are focused on informing the quality of care and research prioritization, and there is a lack of methodology and approaches on how to use guidelines in all the rest of the roles that I just described. That's everything that I have for today. Happy to take any question that you could have. Thank you very much.
So thank you very much, Dr. Flores. I think that is brilliant. You've nicely exposed to us how much more guidelines means and how much more guidelines impacts our lives beyond the usual clinical patient encounter for decision making. So I open this now to questions, requesting again delegates to please type in your questions in the chat box, and then we'll take them up one by one and Dr. Flores will address them. Thank you. So while participants are thinking of their questions, I just wanted to ask a question myself, and that is, you touched upon the fact that guidelines can be used in judicial situations, wherein for legal frameworks, they come in handy. There is a different view sometimes that guidelines are basically guidelines, that they're not rules. So does it matter, in different parts of the world where the guidelines actually stand up in the court of law, in the sense that if a physician has not followed a guideline, and can defend his practice and give a justification for not following the guideline, would then he be liable to penalties and legal proceedings against him?
So that's a good question. It's as I said, a very controversial topic about what would be the role of guidelines in judicial decision, malpractice litigations. And the literature is vast. Just to let you know, there is a lot of this. Most of this literature comes from the US. Has been a lot of cases of malpractice litigation in which guidelines have played a role. The experts on this kind of literature that explore how guidelines are or can be used in judicial decision stated that there are two different approaches. One is that you use it as a sword, which is to accuse a doctor. So the lawyer can use it against the doctor, or on the other side is to use it as a sword. And using as a sword is to use the guideline in order to defend yourself from the actions when you're in a malpractice litigation. So most of the literature is focused on as a sword, as a tool to accuse a doctor that is under a malpractice litigation. So there are voices in favor and against that. Of course, guidelines are not mandatory, and you should not be obligated to do what the guideline says. And also, you could deviate from the guideline recommendation if you as a doctor has a reason, a very good rationale to do a different, to take a different decision from the guideline, what the guideline is recommending. So most of the discussion that is in the literature about the use of this is that most of the lawyers, at least in the US and at least in the literature that is available, are very aware that the guidelines are not mandatory, and they just use it as one of many other factors, characteristics, and information that they use either to accuse or either to defend. So it's not going to be the final tool to accuse or to defend. It's just one additional evidence that the lawyers use in the process. And most of the literature discusses about that. And there are a lot of experts in the literature criticizing guidelines shouldn't be part of the discussion in the judicial decision. So it's a very controversial. We just highlighted that it has been used, and it could be used in both roles. And we are not suggesting to make guidelines thinking about that. That's why we don't think it's a main or a secondary role of guideline. It's an anticipated one. We don't suggest guideline writing recommendation thinking about that, but we also suggest guideline developers being aware that they could be used for this purpose, even though we don't think, many people think that shouldn't be used, okay?
Perfect. And we also have a question from Patrick, who's asking if there is any literature you found on the effects or the impact of culture, on the effects of misinformation on acceptability or usability of guidelines, or was this one of your interests actually?
No, we didn't focus on the effects of impacts and culture or the effects of misinformation. We were just interested in what are the roles. And we have a huge list of roles that we know the guidelines are used or have been used or should be used. We try to categorize and to see which one of those roles, which were the roles for which guidelines were there. When we are doing a guide, when we're developing all these systematic process, as developers or a panel, who are they thinking to impact on? They're thinking impacting on the clinicians and patients, of course, but at the same time, are developers at the same time aware that many of these recommendations are going to be used for economic decision, are going to be used for decision, for health policy creation, for health service organization, for judicial decision. Just wanted to highlight what were those roles. We were not specifically interested in what was the acceptability. However, when we found a role, we tried to go more in depth to identify what would be the barriers and facilitators of those specific roles outside the clinical encounter. But I don't think that doesn't necessarily cover your interest, Patrick, so sorry.
Yeah, we're actually all focused on this issue because we know that one size doesn't fit all. And so maybe another day we'll have a good discussion on this as well, of how local context local issues, cultural issues, and things like that are also, affecting these things. So I see that there are no other questions again for Ivan. I'm just taking a quick final look, and there are none. So it is a great privilege to thank you, Dr. Ivan Suarez. Sorry.
Yeah, sorry, Joseph. Yes, I think someone put a question in the discussion forum. It's not in the live question and answers, but it's in the discussion, but maybe could he also look at that? It says, do you think that the methods of guideline development need to recognize these different users? And does this mean that methods need to vary or adapt to address these other users? That's from that.
Thank you for the question. I don't know who did it, but this is very interesting because one of our main concerns was, should we adapt guidelines to these roles? I'm not saying we need to. I'm not saying we need to adapt to judicial decision. We are saying that there are many roles out there that perhaps some developers could think, not necessarily adapting, but maybe thinking about them when they are doing recommendation. And we would think that depending on who is funding the organization, the guideline, sorry, if this is a national guideline that is interested in impacting in quality of care and perhaps in economic decision, maybe we need to adapt to that specific final aim. If we know that in a country, these guidelines are going to be used to create exam of licensing or certification of specialization, maybe we need to kind of highlight what are the most important recommendations that we think people who are developing these exams could use in order to create the test or whatever. So I don't think we need to, but it depends on what every guideline group, in which field or in which role do you want to have some impact. Maybe you should consider perhaps not adapting or creating appendices or summaries that could help, or tools to could help these other users that are beyond the usual clinicians and patients roles. So that is really a field of further research that we think we could pursue, because for instance, research prioritization is a very interesting role that we think we are not covering well. Guidelines are an excellent source of identifying research gaps, and very few countries are working on that. The UK has been a leader on this, and many other countries could use them to identify what are the most important research and perhaps promote research recommendation, as many guidelines use, that could be used as for the decision of where to put the money for future research projects.
Yeah, thank you indeed. I think I must, recognize Bertha Shaw has brought up a very, very important issue, and I think we'll hear more about this and learn more in the future on this aspect as well. Because ultimately, guidelines are meant for users, and what use it is put to will definitely have an impact on the way it is done and the output as well. So, Patrick, I think there are no other questions now. I quickly scanned both the question and answer box as well as the discussion forum. So do you think we are good to proceed to our third presenter?
Yes, I think we can proceed. Great. And we're doing very comfortable on time. So the next talk is on developing user typologies to better understand the users of NICE content and how it can better support them in their decision making. And this is going to be presented to us by Laura Delaney. Laura is an audience insight manager at NICE and has a keen interest in understanding what stakeholders and users of NICE content need and how they use the information on the website to carry out their day-to-day work. Laura, you have the floor. Thank you.
Thank you. Hopefully you can all see my slides on screen now. So hello everyone, my name's Laura Delaney, and as Patrick's just said, I'm an Audience Insight Manager within the National Institute of Health and Care Excellence, or as some of you will more commonly know as just NICE. I've been at NICE for nearly 10 years now, and my focus and passion is exactly what this session is about. So it's creating guidelines, but with and for users. So I've been leading the user research programme for a large project centred around improving the presentation of our guidance called the Integrated Guidance Project, And today I'd like to share with you some of the work we've been doing to help you put users at the heart of this work. So just to provide a little bit of background on the project, as part of NICE's 5-year strategy, we're reviewing how we present our guidance to ensure it's useful, usable and used. To support this, the Integrated Guidance Multidisciplinary Team has been pursuing how we can better present our guidance. So therefore, knowing our needs and characteristics of our users is vital. And in this presentation, I want to share with you the approach we've taken to ensure that our users are central to what we do, and the work conducted to develop a set of typologies that have helped to bring NICE users to life. So, as it was just discussed in the previous presentation, our audience is vast and it's growing. So not only do we cater to the health and social care sector, which in the UK includes over 3 million individuals representing a variety of roles, responsibilities and types of organisation. But as shown on the slide here, it's not just that sector. Our audiences cover a lot more audience groups. And our audiences are continuing to grow and branch out into different fields, for example, the emergence of digital health and the growth of informed patients. And while some of our users tend to be experienced and they've learned how to access our complex content, our first-time and novice visitors, particularly in the newer audiences, can quickly become overwhelmed or alienated by our clinical tone, but also the breadth and depth of our products. Also, amongst users, there is a desire for more tailored guidance or advice that meets their needs. But obviously, creating individual products that are personalised to each audience's needs would be a near impossible task to create, evolve and maintain. And then when you add into the mix other factors that can impact the type and level of information that users want. So we have organisational factors such as resource, culture or management, individual factors such as time, training or their own individual experience of NICE. Trigger factors, so the task they're completing and where they're completing it. And also factors relating to the content, so is it a change in practice? Are the financial implications attached? How much evidence are behind the recommendations or guidance that has been produced? So the challenge is balancing the needs of the different audiences and determining where we can add most value. And so we must consider how we structure, label and categorise our content so that it can be presented and accessed in a way the user wants or needs, but when they need it. So although it is important to know our audience groups, simply identifying these audiences has not really allowed us to address the user needs. So in order to bring this to life a little bit, I wanted to show how this works in practice, and the test case that I'm giving is me. And over the last month, the use of one website, which was my daughter's school's website. So there was one scenario where I needed a telephone number for the absence line. It was in the morning and things were very crazy, and I just needed the answer to a particular question. There was another scenario where I had an email to let me know that the latest newsletter had been produced from the school. So that prompted me to go onto the website to find the newsletter and to read the newsletter in full. And then another scenario with all the changes occurring with COVID policies and procedures within the school, I proactively went onto the website and sought out the latest procedures and documents, reading them through thoroughly to make sure that I understood, but also following links to external websites that they put up to local council websites and national advice. So that example that I've just given has shown that my needs change depending on the situation and the environment that I was in. So the individual obviously may remain constant, but the variation in user needs were actually determined by the prompt to search. So to adapt this to NICE users, so as I've mentioned, the complexity of our audiences combined with the breadth of information available on NICE means that there are many user groups who have various reasons for using NICE guidance, which in the past has made it difficult to segment our user groups and explore their needs to know how to better present and develop our guidance. So we conducted a detailed collected overview of previous user research that we had conducted and supplemented that by in-depth interviews. And it emerged that there are some homogeneous characteristics of users and their requirements from NICE when segmenting by scenario, by the scenario that prompts the needs for advice. The characteristics identified via this segmentation actually shared more similarities than any other groupings used previously, such as role or setting. So for example, it was clear that not all GPs displayed the same characteristics when searching for guidance or recommendations, nor did all the professionals working in a hospital trust, for example. So let's take a look at the typologies that we've developed. So to start with, there was a grab and go user. So they're looking for something specific. So often an answer to a specific question. So for example, what is the blood pressure threshold for treatment? So their need is a quick, simple, easy to access information. And then you've got the topic foragers who may be doing an initial topic scan to see what NICE has available on a certain topic, say diabetes. So an example of use could be, does NICE have anything to help with my service redesign for a diabetes service? They want clear navigation and content to be reassured that they've found everything that NICE has to offer on that topic. And then you've got engaged explorers. They will actively engage with all levels of NICE content on a specific topic. For example, what does NICE guidance say and what evidence inform this? They need easy navigation through the layers of NICE information and clarity of some of the reasoning behind the recommendations. And then finally, we've got an update seeker. So they're seeking the latest information. So for example, what's the latest COVID-19 advice? They want a summary of the latest updates published. So since the emergence of the typologies, we've been conducting further testing with our users to ensure that they recognise and relate to the characteristics of the identified typologies. And the user research that we've carried out so far has suggested that they do. So in a recent piece that we conducted, it revealed that users felt that their search behaviours are related to at least 2 of the typologies. Many said 3 or 4, highlighting the point on the slide that I think is really important, that an individual may fall across different typologies depending on the scenario or the task that they're faced with. What we're planning to do is obviously, as our users develop and grow, and as we learn more about these users, in particularly the newer users of our guidance, we will develop and iterate these typologies so that they're a living representation of our users. So how does this apply in practice? So this is an example of a GP that we spoke to in a recent round of user research who has a specialist interest in diabetes. And this demonstrates the different needs that the one GP has when faced with different scenarios or tasks. So obviously shown on the screen there, a variety of scenarios that they've been faced with, either wanting a quick search for something, they're keeping up to date, or they want to spend more time looking through and reading through the different levels of information attached to one piece of guidance. So this is showing that a GP can wear many hats in their role, and their needs will change depending on which hat they have on or what scenario they're faced with. This highlights the limitations that we would face when trying to write and present our guidance based on groupings such as roles, whereas using typologies allow us to be close to the user needs rather than trying to make them fit into a predefined category. So the typologies has been used as a basis for the integrated guidance project that we've been working on within NICE to ensure the work we are doing to improve our guidance and the presentation of our guidance is based on user needs. And an example of this is shown on the slide. So for each phase of the research, a typology has been identified and explored, ensuring users are at the heart of the work. We've used user journeys at the start of each phase, which are scenario-based, as are the basis of the typology, so it lends itself to this approach. And this helps to explore and delve further into the user need in the whole scenario and not just that one interaction with NICE and our guidance. The whole process was based on the typologies shown there, which channeled focused thinking and put ourselves in the user's shoes. And we tested this with ongoing user research. The content design work was then based on this. So what have been the benefits realised by exploring the typologies and putting them at the forefront of the project? So it provides a framework, a starting point. We've had the benefit of having an initial understanding of the broad user needs for each typology. So we're not starting from scratch, which makes obviously the initial groundwork of the user journey mapping, etc., a little bit easier. It stretches the boundaries of research, not only from the point of view of breaking traditional segmentation boundaries, but also in terms of recruitment. So the net can be cast a bit wider to provide more rounded views of the user needs. It also challenges internal assumptions and perceptions, because we want to make sure the work that we do is based on research, even user research, rather than internal assumptions and perceptions. It provides a usable use case. It brings the users and their needs to life, which in turn makes it more relatable in discussions across multidisciplinary teams with guideline developers, designers, content writers, editors, etc. And it helps to bring users into the conversation because it becomes familiar currency, and colleagues across the organisation at all levels have a level ground to assist discussion. So we now have members of our executive teams bringing grab and go users and engaged explorers into conversations. And so what has this meant? So by considering the task that prompts the user's behaviour, we were able to more easily identify and verify their needs. So this formed the basis of the content rewrite that we've been trying out, which was met from positive praise when tested with users. This will obviously help to further develop templates and content design principles for our current and future guidance to ensure our guidance, as we mentioned from the start, is useful, usable, and used by our users. Thank you very much, and I'll be happy to take any questions that people have got.
Thank you, Laura. I think that has been a very interesting presentation, at least speaking from my perspective. It's new insights for me to be able to listen to a presentation like this. I'm sure Patrick agrees with me as well. I'm going to now take a quick look at the chat box to see if we have something going on there. And I find that Yang Song from Canada has made a comment. So maybe the implementation strategy could engage those findings, and she compliments you for a very nice presentation. Yang Song, do you have a question there? Laura, would you like to comment on that comment?
Yeah, I think it is just kind of this change of thinking, and obviously, as we've the presentation mentioned before my presentation by Ivan, is that obviously guidelines, the audience for them is vast and it's growing, and it's about understanding how, not necessarily how we write or develop our guidance for them, but how we present as well, how we present that content so that people that do want to use our guidance can use our guidance, and it's broadening beyond those traditional audiences that maybe we've just considered as guidance users before. So it is bringing the users in at the start of the guidance development, not just kind of testing it at the end once the guidance is already developed.
Okay, thank you, Laura. And we have another question now from Jennifer Francis, who's saying, again, complimenting on a very fascinating presentation. And she says the social care sector is a relatively new group of guideline users for NICE. Have you identified any differences in the typologies across that sector compared with your more traditional clinical users? And if so, how has this affected the implementation of the social care guidelines? I think very important question. Thank you, Jennifer.
Yeah, absolutely. And social care is an audience group that we're trying to bring in, and we're heavily including them into the integrated guidance project. In actual search behaviours, the search behaviours that are coming through relatively are quite the same. So, you know, you'll want someone who'll want a quick answer. What we are finding is that with the social care, our social care audience, is that The evidence base is obviously can be a lot different, and the way that they explore the evidence base, and I've been used to using that evidence base before. So this is certainly something that we want to explore in more detail in this integrated guidance project. And we're working with our social care team with that to make sure that we're including feedback and bringing that audience into our user research as well, to make sure that we get the voice of them. And as I said before, obviously these typologies have been developed based on previous user research, but as we engage more with our users and certainly our newer audiences, we're very open to develop and iterating the typologies to obviously incorporate these newer audiences if there's different behaviours that we need to factor in.
Thank you, Laura. I think that's very insightful. While I'm waiting for another question, I have a question of my own. I mean, the very term, audience insight manager, means that NICE is heavily invested in understanding the needs of the end users. And so now we're tailoring guidelines, not just, here it is on a platter, take it or leave it, to understanding their needs and trying to cater to that. Are you aware if, similar positions exist in other prestigious guideline developing agencies across the world, or is this unique to NICE? Which I'm sure means that others will catch up very soon.
So yeah, within the UK, I'm aware of colleagues in other guidance development organisations that do have sometimes the terms is very different things. So it could be kind of user experience researchers, user researchers, there's different terms, but I think more guidance developers are bringing in the voice of the users a little bit more now, and certainly within NICE, it's something that we are finding putting users at the heart of our guidance development is key. So yeah, we're very passionate about doing that.
Perfect. And we now have another question from Awe Ekofu. I hope I've said this correctly. And he's complimenting you too, Laura, on an excellent presentation and asking, did you experience a situation where users were reluctant to take up the evidence? And if yes, what did you do in that situation?
So would that be, I'm assuming that's kind of who we're presenting that back to, so kind of internally. So yeah, you can, as a user researcher, as an audience insight manager, you can meet barriers because just naturally as humans, we have our own biases, we have our own assumptions, and some, we can feel quite strongly about them. So you do, as an evidence-based organisation, we're evidence-based in terms of developing our guidance. So it's only right that we need to be evidence-based in terms of our user research. And it can't just be based on internal assumptions or that one person's mentioned this at a conference, or, we have to try and break that down. And so we have been engaging a lot with our internal colleagues at all levels to really show the value of user research and showing the case studies where user research has been done and the benefits of doing that. So it has been a bit of a process to obviously establish user research and the benefits of that. But I think once you get your sponsors on board and there's people that can champion you, and really put forward that as an evidence-based organisation, we should be using evidence-based into terms of user research. The organisation is certainly on board in terms of that. But yeah, I appreciate there are barriers that we do have to battle through.
Yeah, I can guess pretty much as well. And I'm thinking here that industry has been ahead of the game for a long time, They have specific marketing strategies, tailor-made things for different demographics within a population base. And I'm just wondering, will we see the day in which guidelines will have to be tailored not just to a broad term of users, but then look at subgroups within users, I don't know, by gender, by age, by social status, economic, I don't know. Maybe we come to the day where we have to make personalized guidelines pretty much for at the individual level, do you think?
Yeah, well, that's certainly, our users, it's certainly a message that's coming back from our users. People do want personalisation. We all want that when we're going to search for something. We want literally the website that we're going on whether that's for personal needs or professional needs. We want it to bring up the information that we need. We almost want the website to tell us, we think you should know this, rather than us actually having to go and seek the information. So there's certainly a demand for, our users are wanting that personalization and that tailoring of content, so that, especially for a website like NICE that's got such broad and in-depth content, it can be quite intimidating to go on to view all our guidance and leave the website feeling reassured that they've found everything that they've needed and not missed anything, especially in such an important field. So yeah, I'd say that's definitely a message that's coming back from our users.
Perfect. And this is a fascinating discussion, Laura, but I'm afraid time is, flowing.
Absolutely.
I'm sure we'll have a lot more to discuss on this, and hopefully in some other forum. So thank you very much on behalf of Patrick and myself for a very fascinating presentation. And I defer now to Patrick to take up the next session. Thank you, Laura. Bye.
Okay, thank you very much, Joseph, and thank you very much, Laura. That was really fascinating, very interesting. And our next talk is on patients and caregivers' perspectives on outcomes of self-management interventions for type 2 diabetes mellitus, an overview of reviews. And we come back to, Ana Nino de Guzman. And we don't need to present to you again, because we just heard your presentation, and your previous presentation was really, really interesting. And really congratulations for having 2 oral sessions. The competition was really tough this time around. So to have 2 oral sessions, those who had this must have had a good job. So Anna, please go ahead.
Thank you, Patrick. And I will share my screen now. Okay. This is the second topic I will present. Well, this is an overview of reviews. In this time, we are focused on the patients' and caregivers' perspectives on outcomes of self-management interventions, but for type 2 diabetes mellitus. So just to remember what is diabetes mellitus, is the main idea here is we have high values of glycemia, we have an hyperglycemia, and this hyperglycemia, these constant levels, leads to microvascular and macrovascular complications alongside all the trajectory of the patients. So diabetes mellitus is associated with a reduced life expectancy, significant morbidity, and diminishes quality of life. And broadly, and economical and the society represents a burden for health systems and mostly for patients. And the heavy impact is more for low and middle income countries. So we agree that just in this session and in the process of making recommendations, we need to include how patients value their preferences regarding any treatment or any intervention. So in this particular disease, like in others, it's essential to help patients to do or to make informed choice. So one of the strategies that help patients to be and to manage their disease is to include self-management interventions. And these interventions have shown beneficial effects. They represent one component of the chronic care model nowadays. So the objective of this overview was to understand what mattered most to these patients and their informal caregivers regarding the process and outcomes of self-management interventions. We conduct this overview systematic review. This was registered in Prosper previously. We searched in 3 databases. The first search was conducted until December 2020, where we are still monitoring in PubMed just until finishing the data analysis. We use a content search strategy designed for the values and preference that was previously published, and specific terms for diabetes mellitus. We use methodological filters available in each database, and additionally, we conduct a forward citation of selected systematic review in Scopus. So here we included studies that were including only qualitative studies or non-utility values measures. So the ones that, for example, use a cross-sectional design were also included here. So here we included the studies were based on patients in adults with diabetes mellitus or in former caregivers. So here we excluded gestational diabetes or other type of diabetes. The phenomenon of interest, we were focused on these population preferences on outcomes and experience with self-management. So here we go in a deeper analysis of what we done in the previous scoping review. Here we evaluate the quality of the systematic reviews using the Johanna Briggs Institute checklist. We also calculate the overlapping of primary studies using the methods of the corrected covered area, and we apply our thematic synthesis. We use an inductive and deductive iterative approach. We first develop the descriptive themes, then the analytical themes, and we apply the framework CompareU for outcomes of self-management interventions to present the findings. So the products here of this overview were, in one side, summaries. So we developed one summary per each outcome of the core outcome sets. In this case, for CompareU, they selected 23 outcomes for self-management interventions for type 2 diabetes mellitus. And we also conducted, or we are in the process of conducting a survey that we will assess patients and caregivers' reactions to the final summaries. I will show you the final summaries, how they do look now. So this is just a graph showing how we did the interpretation, how we did the coding. We included the second order, our third order constructs focus on what were described from primary studies. So we only use the source of evidence, the systematic reviews, and we use the second order and third order and develop and propose the descriptive themes first and then analytical themes. So far we identified 55 systematic reviews. Most of them are considered of high quality, and they show a slight overlap. So according to the covered area formula, lower than 50% is considered as a slight. Most importantly, just to remark that we could identify more than 1,000 primary studies, index primary studies, putting all together these 55 systematic reviews. And then we could identify evidence for 23 outcomes. So just to show you how we work, we develop one summary per outcome. In this, you can see in this shop, you can see how we identify the outcome according to the CompareU taxonomy. For example, here you can see knowledge. This represents one outcome of the subdomain called empowerment components. And here you can see the definition we use for CompareU. And in the first row, you can see their descriptive theme. And in the next paragraph, you have the supporting findings, focus, and in trying to make summarize narratively and integrating the findings from different, you can see several systematic reviews that consistently show one finding. So this process was conducted for each of these outcomes. And after identifying the descriptive themes, we follow and conduct a final analytical theme, just looking the descriptive previous one. And for example, for knowledge, this was our main theme, the main analytical theme, after looking all the nuances, all the different shapes or angles of perspective. So, for example, in knowledge, you have here knowledge provision should consider patients, information needs, training preferences, and health beliefs. When it was possible, we could gather also evidence for informal caregivers, and we highlight there explicitly in the brief summary. So that's we call the brief summary. I know it's redundant, brief summary, but that was the name we gave that. And after that, we also presented what were the sources of the systematic reviews that were informing this summary, and highlighting some specific characteristics of the systematic reviews. Just one example, if you look at the 17, the SOHAL 2015, they included patients from South Asia, for example, only. And maybe in the other ones, you can see others were not specific, they were broad, and just we put adults with type 2 diabetes mellitus. So we highlight only when there was a highly different characteristics. So now we are in the dissemination phase. We are asking patients with diabetes mellitus and also the informal caregivers of family, and to assess the understandability and coherence of these summaries. So if you look at this QR, we will be happy to have your feedback, or to have, if you know some people that fill this profile. So it's okay. We are open this survey until the end of November. And well, we split the 23 outcomes in 4. So you can see 4 QRs here. We split the 23 in 4 just to avoid the people getting tired, because the brief summaries are not always brief. They maybe some have more than 12 lines, and we are asking 4 questions. So just to avoid the tiredness. And we also are conducting the analysis, a further analysis, just looking all the 23 outcomes, descriptive themes and analytical themes. We are doing this further analysis to find an overarching theme that can integrate these findings in some way, just to present this finding in one way. Just how what we notice here in our analysis, that the evidence emerge from different point of views, and sometimes they consistently appear in different outcomes. So here we were discussing how we present this data, and we try to do a figure like the previous one in the scoping review, but we feel that it could lose some the richness of what we have identified. So we propose this as a final summary, just to integrating the interaction between the different findings we identify according to the outcomes, and how they consistently reflect others' perspective of how they interact between each one. For example, here you can see, I will read only 1 or 3 sentences. For example, health literacy influences patients' healthcare access, and knowledge provision is better received in a positive patient-provider relationship. Just to look in that sentences, you can imagine what was the interaction, how the findings regarding healthcare access and knowledge and patient-provider relationship was always in the same tone. They were always looking and they were reflecting the same findings. Well, this is very interesting, but well, it was required iterative discussion among the group. So far we are 3 people here in discussing this. And so this is, I guess, an intermediate version of that. So the key points that we have identified: rich and thick qualitative findings, exploring patients and caregivers' perspectives for most of the outcomes. Despite not all systematic reviews are focused on self-management interventions, we provide a comprehensive picture of what is self-management experience as a whole process during the process of patients integrating self-management, in this case, for patients with diabetes. So we feel that these findings can inform the previous process, the core outcome sets, decision-making process, and the formulation of recommendation, and designing and implementing some new self-management interventions to just to have in a handly way, in a handly manner, the evidence focus on different outcomes. So we are working now, we are in CompareU. This is also conducted in the context of CompareU, this project. In CompareU, we have identified some self-management interventions that were prioritized. And in this, we are including a panel of patients, representatives, experts, methodologies. So there are different panels for the 4 chronic conditions. For diabetes, we have some meetings so far, and we are including this evidence from the qualitative data that are informing the values, acceptability, and feasibility criteria. We are preparing the ETDs, and we are also applying since we need to provide an assessment of the certainty, we are applying the circle approach for the findings that are informing these criteria. So just to mention some first lessons about this process is that despite we have done the brief summaries and the summarized evidence for each outcome, they still are large. So we need to summarize more and to develop more brief summaries and adapt to the ETD purpose and format. So the wording we are using requires a double check and iterative revisions before presenting the data to the panel, because we need to find balance between being clear enough and also a methodological exhaustivity. So it's kind of quite difficult, but we are proposing formats of developing like the one that you can see here. Like we are presenting the outcomes and the findings and some prejudgments of the variability and one assessment of the certainty. So CERQUAL helps to assess the certainty. Relevance and coherence are the most importantly criteria that we are checking. And just to highlight some finding that we need to be careful in the relevance of the findings, because since we are using systematic reviews, we are using the third order findings of these highly specialist, qualitative specialists that have to conduct a systematic review. So maybe we have the risk of representing the findings of the authors of these systematic reviews. So just to have that in mind before doing this type of reviews, that we need to have also a balance between how much information or how much weight we give to the second order findings and compared to the third order findings. So the third order findings could be some type of bias, but also if you look in the other sense, having the expertise of a qualitative expert that had conducted a systematic review just has elaborated a work. So just to have the balance also there, how to present the balance between these two types of evidence. And finally, we also have challenging to evaluate the quality of qualitative evidence synthesis, because it's still debate about how to evaluate these type of studies, because it will depend mostly in the methods and the approach they apply. So that would be all, and I will be happy to answer any questions.
Thank you again, Ena. Nice presentation as the previous one. I'm just going to peep into the chat box to see if we have any questions. We don't have any right now. Okay. Yeah, so no questions in the chat and no questions in the live Q&A as well. So while people are thinking of questions, Ena, once again, the opportunity to you to make any additional comments which you could not include in the presentation because of the limited time, this is the chance. Go ahead, please.
Thank you, Joseph. Well, maybe to mention the process, just how we are conducting the development of the summaries. So at the beginning, we expected not to spend so much time reviewing them. And well, we need almost 1 year to develop these summaries. So I guess we are trying to do the triangulation using finally we will be able to do the triangulation of the data, because with the survey, we would like to have the feedback of real patients and real caregivers, just to read the summaries and explain first the understandability, but also how this experience that were summarized here reflect their real experience in real life. So it's something that we recommend or use for users to participate in systematic review. So, well, this is also one innovation we want to highlight, because we feel that since we are exploring patients' perspective, that was logical to ask one or at least a group of patients to read our summaries and say what they think.
Thank you, Laura. I think that's very helpful. Now, I have no questions from my side, and I'm still seeing none in the chat box. Patrick, would you like to make any comment or ask any question here?
Yes, so I would just quickly comment on the importance of qualitative evidence synthesis. It's something I found coming up in her talk. However, this sometimes has not yet been very, very popular in the evidence synthesis world, and for the use of this for recommendations. And I believe that once we start thinking about engaging users more, then we would be moving away from the numbers and the quantitative data. Will be going towards the experiences of people with clinical practice, clinical encounters, as Evan was talking about. So I really appreciate that approach, and I'm happy that this came up in a lot of the talks. What I would just want to say is for the three panelists to tell us if they see some interrelationships between what you are doing and what the other presenters have presented, or there is none. Are there any opportunities for learning, etc.? I'll just be interested in hearing a little bit more about this. Thank you.
Yeah, and it'd be great for everyone to, switch on their video cameras and everything so everyone can see us all. Please go ahead.
Yeah, I certainly, in terms of the last presentation and obviously Ivan's presentation on the different users beyond kind of the clinical users of guidance, it really resonates with the work that we're doing, and obviously bringing in kind of the user's voice and user's feedback, and that kind of more the qualitative data. Obviously, as user researchers, we use both. We use quantitative and qualitative data to come to our conclusions. So yeah, the two really resonated, and yeah, it certainly reflects in some of the work that we're doing as well.
Yeah, that's just great, And Ina had a comment to make as well.
Yeah, yes, I agree with Laura. Yes, I guess we resonate in some spectrum, because in one side, Laura mentions how is the interaction of the user with the guideline website, and how they find the evidence. So it's what's very interesting, the different behaviors, the different profiles we have for users. So nowadays, I guess it's very important, the use of websites, because sometimes it's the first attempt of searching information. So it's something that we need to take into account. For example, in the project of CompareU, we are developing a decision aids, and we are trying also to produce a format that can be easily accessible to the patient, so they can get the main message in one shot. So the process of doing the information in plain language and shorter and straightforward, so it takes time, so it's time consuming, but I guess the benefit is the patient is really well informed, and finally, when our objective is that they can make informed choices at the end. So yeah, and regarding Ivan, also how the clinical guidelines go in different areas, also they can be really informative in the clinical encounter. It's not only one way of applying the guidelines, and also highlighting that clinicians or people who use the guideline can deviate from the guideline, but consciously, just knowing that we are deviating because we are talking with the patient and we are deciding that for this particular patient, this doesn't work, this would work. So just the integration of those data, I guess it was really nice.
Excellent. And we've actually run out of time. We are exactly at the time we're supposed to finish. So over to you, Patrick, to close this session and thank our speakers. From my own side, thank you. Over to Patrick.
Yes, so thank you very much to all of you. It was a very enriching encounter, and I do hope we get the opportunity to get this kind of talks in subsequent GENE conferences, and hopefully see you in Canada next year. So thanks, everyone. Bye-bye.
Bye-bye.
Thank you.
Have a great conference. Bye, everyone.
Bye.